Hi, thank you for the opportunity to talk about Focused Ultrasound-enabled liquid biopsy of brain tumors at the workshop today. My name is Ying, and I work with Dr. Lipsman at Sunnybrook Hospital, and we work on clinical applications of focused ultrasound, particularly in the brain. Disclosure, I don't have any personal disclosures, but the results reported in this presentation are from a study funded by Insight. Liquid biopsy is it's a very promising application of focused ultrasound. Liquid biopsy is the peripheral sampling of tumor-related or pathology-related biomarkers in the bloodstream. It offers the advantage of being less invasive than, for instance, an open biopsy, and can be done longitudinally along the patient's care pathway to, for instance, monitor disease, diagnose a treatment response versus a recurrence, and presumably earlier time points than the occurrence of symptoms in these patients. One of the challenges of a liquid biopsy is that an abundance of other biomarkers, including proteins, DNA, are already in circulation in the bloodstream, and to detect smaller levels of tumor-related ones is very difficult. And obviously, many technologies are being developed to advance this field, and significant strides have been made in this field to circumvent these challenges. So liquid biopsy for brain tumor, however, poses an additional challenge, and it has been shown in a seminal study in 2014 in patients with brain tumors, particularly gliomas. The frequency of cases with detectable ctDNA or circulating tumor DNA is significantly lower than in patients with systemic cancers. And this is thought to be, at least in part, due to the blood-brain barrier. The blood-brain barrier limits the entries of compounds and drugs into the brain, and this is a two-way street. It limits the shedding or release of biomarkers into the bloodstream as well. Another hurdle in the liquid biopsy of glioblastomas in particular is the significant spatial heterogeneity of these tumors. It can be challenging even for open biopsies to have a good sampling of all the aspects of the mutational status of the tumor. So this is where focused ultrasound, BBB opening in particular, can be helpful. Not only can non-invasively open the blood-brain barrier and potentially enhance release of biomarkers, but also has very high spatial resolution that can be image guided, and potentially we can selectively sample different areas of the brain tumor based on neuroimaging and make very smart decisions about how to treat glioblastomas. This again is demonstrating how FUS BBB opening works. So microbubbles under the exposure ultrasound oscillate very quickly and mechanically disrupts the blood-brain barrier. The idea is that during this procedure, the BBB permeability increases, and a greater release of biomarkers like DNA, RNA, exosomes, proteins, and cells are more readily available by detection of a blood collection. The first animal study that showed the feasibility of this approach was done by Dr. Chen in a glioma model where a GFP transfected glioma cells are implanted into a rodent brain. Focused ultrasound-induced B opening enhanced the plasma concentration of GFP mRNA by over 1,000-fold. So this is a very promising result. Further proof of principle study was done in porcine model, where a greater level of brain-specific proteins were detected, specifically GFAP and MBP. In clinical trials, in several devices are early phases of clinical trials. These include the Insight device, the Carthera device, and the NaviFus device. And these are all promising avenues for investigating liquid biopsy further. In our group, we use an Insight device in patients with glioblastoma. This particular study has the primary aim of establishing safety and feasibility of combining focused ultrasound with adjuvant TMZ. So with the first dose of every TMZ cycle, patients undergo the FUS procedure, and before and after the opening, we collect their blood samples. On the right is basically a demonstration of increased gadolinium leakage as a result of focused ultrasound, and the recovery of the blood-brain barrier permeability the day after. So we took these blood samples and we isolated cell-free or cfDNA, and we found a significant increase that is consistent through every case in the pre and post FUS samples. And also looking at, for the quality of cfDNA, the length of the DNA from 0 to 280 base pair was also significantly increased, indicating that this increases indeed good quality and not just a whole genome contamination of the sample. The level of increase that we saw did have a weak correlation with the volume of BB opening, which is in line with our hypothesis that BB opening can increase release of biomarkers. However, we do not see really any relationship between the time elapsed from the last sonation to BB opening, time lapse from the last sonation to the blood collection. However, really the study was not designed to investigate the dynamics of these biomarkers over time after the last sonation. We did not, in patients that had a gross total resection and subtotal resection, we did not see a new relationship on the effect of focused ultrasound on cfDNA levels. However, in patients who eventually went on to have progressive disease, we saw that focused ultrasound had a greater effect, greater enhancement of cfDNA levels on their last treatment cycle versus their initial cycle, which is an interesting result. We also looked at other biomarkers, including neuro-derived extracellular vesicles, and there was a significant increase there as well as a result of focused ultrasound. And as more of an exploratory analysis, because we want to further investigate whether the cfDNA increase was increase of the same profile of DNA versus new types of cfDNA that's released in the bloodstream. We looked at the methylation signature of the different samples, and using a PCA analysis of the microarray data, we demonstrate there does appear to be a distinctive signature between the pre and post FUS samples, and that again is not just more of the same increase. Looking at the significantly differentiated methylated probes, we see that these probes are predominantly hypomethylated compared to in the post samples compared to the pre, which is consistent with an oncologic signature. And further pathway analysis of the differentially methylated probes show that these probes have an origin of lymphatic signature and neuron glial signature, which is again a really interesting result in keeping with our hypothesis that focused ultrasound can enable the liquid biopsy of brain tumors. Again, these results are in the early days, and more data has to be collected on whether the enhancement of biomarkers can be correlated with the original tumor tissue biology. So, in summary, focused ultrasound enabled liquid biopsy can be applied in numerous points along the care pathway of a patient throughout their care. Anywhere focused ultrasound might be useful in enhancing the delivery of a chemotherapy, focused ultrasound procedure can be at the same time used to monitor disease progression or disease response to therapy, or predict, for instance, recurrence versus pseudoprogression, and improving the delivery of precision medicine to these patients. In addition, focused ultrasound-enabled biopsy may be applied before a surgical biopsy as well, potentially to aid diagnosis and surgical decision-making, and in the long future, perhaps offer an alternative to open biopsy in certain select situations. So currently there are numerous focused ultrasound studies underway to enhance delivery of various chemotherapies around the world. And all these trials are very resource intensive and offer a great opportunity to incorporate liquid biopsy as a correlative study to further develop this potentially promising new indication for focused ultrasound BBB opening. Thank you for your attention to my presentation. I'd like to thank all the staff in our lab and our collaborators, as well as support over years from Focused Ultrasound Foundation and our various research efforts and CAHR. Thank you very much for your attention.